Welcome to our December TMIT National Research Test Bed High Performer webinar. We are going to cover the topic of the 2016 top 10 health technology hazards and the 2015 top 10 patient safety concerns and our webinars over the year. And I'm really delighted to have you join us today. I'm Charles Denham, chairman of TMIT. And for those of you that have the slides, I'm on slide 2. We want to remind everyone to use your computer and turn the volume up on your computer so your audio can be the best that it possibly can be. And if you can't hear, to click on the telephone icon after you click on the participants window, then click on the request phone icon of the telephone, and we'll help you with the telephone line. I'm on slide 5 to remind those of you to come back to download and to be able to listen to the webinar series and other posted resources, as well as those of you that don't have the slides yet. If you go to www.safetyleaders.org, and so it's safetyleaders.org. In the upper right-hand quadrant of the landing screen, you'll see what's new, and you can click on today's webinar date and download the slides that I'm going through right now. It's such a pleasure for me. I'm in slide 6 to address the fact that we are going to cover a number of topics this morning, and we have Terry Wheat, who is both a quality leader and a trustee of another medical center in one of the safety net hospitals, and a terrific leader in quality and safety, as with me live. And we have Toff or Christopher Peabody from the University of Southern California joining us. UCSF is where he is today as a clinical professor there in emergency medicine, and he'll be on audio with us because he is covering an emergency shift today, and he didn't want to miss being involved. On slide 7 are our social media addresses. On slide 8, just to remind ourselves, our purpose is we will measure our success by how we protect and enrich the lives of families and caregivers. And this webinar addresses our webinars over the year that really address both patients and protecting caregivers, as well as these technology issues, which we'll talk about both for 2015 and 2016. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. On slide 9 is the disclosure statement. We will not be covering any product, service, or technology for which we have any relationship, and the topics that we'll cover are the general areas of technologies, but no specific company's technology. And so our speakers and reactors today are Terry Wheat, who I'll introduce in just a moment, Christopher Peabody from UCSF, Arlene Salamandra, who I will turn things over to in a moment, who will be our patient advocate, patient champion, Frank Guilleteau, our longtime chief technology officer, and I'm going to be our MC. But what we want to do, and I'm on slide 11, is always start these webinars with the voice of the patient, and we'll end with that. And Arlene will open us and close us. And Arlene is a wonderful patient safety advocate. She's been a patient safety peer review article co-author. She helped write the Chapter 9 of the NQF Safe Practices and individual sections in the Safe Practices. She has been a caregiver, and she's been a tireless champion for prevention of bullying and improper use of power in the infrastructures in healthcare, and also was one of the lead people involved in helping get the hacks through more than 5 years ago through our grassroots approach. So it's just such a pleasure to introduce you, Arlene. Go ahead, please, and open us.
Well, I would like to welcome everyone here today for such an important webinar. I believe the beginning steps for healthcare improvement comes from collecting the data and then identifying all these problems. Only great leadership and then true teamwork with frontline workers and everyone involved and informed patients and family members can have a remarkable impact on outcomes. So I'm looking forward to learning about some of the problems that we face in healthcare and what steps we could take to prevent unnecessary injuries and deaths from medical harm. So back to you, Chuck. Thank you.
Thanks, Arlene. as we have been doing over the years, I'll just address some of the articles that you may not have seen and our polling highlights of information you gave us about what you want in the webinars. So I'll move rapidly through those. And for those of you that are catching up on the slides, on slide 13, if you go to the Agency for Healthcare Research and Quality, AHRQ, you'll see on their landing page a title, Making Healthcare Safer and Improving Quality. And if you click on that, you'll get what I have as the next slide, and that is national patient safety efforts save 87,000 lives and nearly $20 billion in costs. And these are the healthcare-associated conditions that were then tied to incentives, where the bottom quartile in the country will pay a consequence of a penalty of 1% of their Medicare billings. And this financial incentive has had an enormous impact, and a number of them, of these 11 hacks, were targets of our safe practices. So on slide 15 is just one part of that report. Now, you can download the report, and in the appendix of these slides, which we won't cover, I've got a lot more of the detail, but you can see central line infections, adverse drug events, surgical site infections, venous thromboembolism, catheter-associated urinary tract infections, falls, pressure ulcers, and ventilator-associated pneumonias were all NQF safe practices. And so many of us worked together to write the arguments in an evidence-based argument that we submitted to CMS to help put the hacks through, although it made a lot of people irritated that they came through. The incentives have had an enormous impact on the adoption of best and better practices and saved an enormous number of lives, and the number's growing. So on slide 16, you'll see that the cumulative number of lives saved is just south of or the dollars saved is just south of 20 billion, and the lives saved 87,000. And it is you, the frontline caregivers, that did this, that had this enormous impact. And if you go back to the hacks, you'll see that many of them originated with the Institute for Healthcare Improvement. On slide 17, what we typically do, rather than load you up with 1,000 slides, is give you the headline, the logo of the media press, the headline, and the references at the bottom of the page. These articles in USA Today, Washington Post, Huffington Post, Washington Times, U.S. News and World Report, Modern Healthcare, and Kaiser Health News are very, very top-flight organizations that have written this up and covered it in the press. And so we created a slide for each one of these, but I won't cover each slide and each one of the reports, but I think you, in your work, as you talk with your constituencies, can address this. And unfortunately, it was one wave of a news cycle, and then other news kind of captured our attention, but it was dramatically addressed and covered and favorably addressed in the media. So if you go to the appendix of these slides, just for convenience, we put them at the end as well. And so the next slide, on slide 18, is this issue of the CRE infections. Now, we had CDC cover that with us this year. We've got people close to us, very close to us, who have lost family members due to infections that were caused by endoscopes that contributed this bacteria to a patient's condition and contributed to their death. We can never say entirely caused their death, but we know that this can be the contributing event. And the real danger, and you'll see on the lowest bullet, is that their ability to transfer antibiotic resistance through a plasmid, through the DNA, a mobile piece of DNA, to normal bacteria to cause resistance. So this is a major crisis, and CDC has helped us address this year, and I'll cover some of those webinars. Another article by John Tassant, excellent article at Harvard Business Review. Don't miss it, December 9th. It addresses how to tackle improvement and the best way to focus with redesign of healthcare. Start with one unit. Excellent article, highly recommend it, and more John's work and the work of the organizations he's been with has had enormous impact and is being disseminated at this time. Also, a modern healthcare article on slide 20 regarding the CMS is posting now quality data on individual doctors, and the AMA, as you would expect, is protesting it, and everyone will want to kind of debate the measures. And but the fact that transparency is coming to medical practice is key. Now, we hear so much negative stuff about electronic healthcare records right now because it's in vogue to talk about what's wrong with meaningful use and it's not what it's cracked up to be, and on and on and on. We wanted to give you one of the favorable articles because we've covered a lot of the negative ones this year, but this is a favorable article about Children's Hospital of Los Angeles, and we thought that this article was of interest, and we put the source at the bottom of the page. And this U.S. E.H.R. adoption model is a great way to help people understand the various stages of adopting electronic records. Terry Wheat's going to be reacting to a lot of what we are covering today, and I know that she is really going to help us understand what caregivers like nurses need to learn to be able to serve as trustees on hospital boards, and decrypting and decoding and helping non-clinical board members understand why they're making big investments and to sort out the wheat from the chaff is so important. And we have Terry is a great champion of that, being a board member, and often asked as a nurse to help decode some of this. And we thought that this organizational structure on E.H.R. adoption that uses the HIMSS analytics would be helpful to you. And so the second slide of that series is slide 23. I won't address it in detail because we have a lot more to cover, but we just wanted you in the news to understand that. I'm going to shift gears now, and at 12 minutes after our start, and I want to keep on time here so we have generous time for reaction, I want to draw you back to our last webinar, which was on November 19th, and we were so honored to have Clayton Christensen by audio and video address disruptive innovation. He is attributed as the single driver of $25 billion in revenue at Intel by providing Andy Grove, at that time their CEO, with the theory of disruptive innovation used as a lens. 2,000 leaders at Intel dramatically changed the course of that company, and the history, then rolled out with his book of The Innovator's Solution, Disruptive Innovation, The Innovator's Dilemma, Seeing What's Next, How Will You Measure Your Life, are all books by our partner and really a national treasure, Clayton Christensen. After he set that up, we had Dan Ford, one of our own patient advocates who's part of a Saturday morning team that get together every other week for years, who is also a leader of this hack grassroots approach, is Dan Ford. And Dan addressed including patients and the root cause analysis and made a really good case for it. Now, we polled you, so I'm shifting gears now to give you polling results of what you told us last month. And if you weren't on our webinar, we asked the question, I need a tactical action plan and practices to include patients and families in the root cause analysis at my organization. Many of you are caregivers who are involved and could have a voice to suggest this. Now, we know that you run a professional risk because this is a pretty dramatic change from, patients and families after an accident say, you mean the people investigating the accident are the foxes that are investigating the death in the hen house? That doesn't make sense. Why not include us in the root cause analysis? And yet many of our risk managers and lawyers and leaders are really scared of having patients and families in root cause analysis. But it's a coming trend, and Dan has been a tireless champion, single-handedly actually keeping this right up front. And he's also working with patient advisory boards and has been a co-author with Arlene. This is what we found when we asked that question. 94% of you last month told us you need such a plan. So we're in January, and in the next 12 webinars, we'll bring it back to you. We're going to bring you some leaders that have done it, how they've overcome the challenges, and what they've done to do so. So we want to let you know when 53% of you gave that a 10, 8% gave it a 9, 94% of you agreed, and only 3% said negative to neutral, and 3% neutral. That tells us you need that in our webinars. We also ask you, with proper tools and successful examples, I would propose to include patients and families in root cause analysis at my organization. 55% of you gave it a 10, 8% a 9, 23% an 8, and you see the rest. So that's 96% of you proposed to include patients and families and RCAs at your organization if you had these examples. So we know, and Terry, we'll have you react to this a little bit later, is this is tough and hard to do. And we hear from you, you want success stories, people that have done it, and the world didn't stop. The clouds didn't drop from the sky. The bottom didn't drop out of the hospitals. And many have had, we hear very few examples of anyone having a problem. So that said, yes, we'll tackle it in 2016. You're telling us unequivocally, go ahead and do it. The second polling question was regarding this IOM report that just came out this fall that said 5% of the U.S. adults who seek outpatient care experience a diagnostic error. 10% contribute to patient deaths, diagnostic errors. 10%, and diagnostic errors account for 6 to 17% of hospital adverse events. We know this was a very conservative report. We know that diagnostic errors, I'm a cancer doctor. I'm right now at Texas Medical Center near where I trained at MD Anderson and Baylor College of Medicine and Methodist Hospital. And we know in cancer that it's as much as 20 to 30% misdiagnosis and 30 to 40% not using the evidence-based trials to treat them. Now, this was a great framework that was provided in the IOM report. We recommend you go back to it. You paid for it with your taxes. It doesn't cost anything to get it. And we put it in the slides. And we asked the question, I need actionable best practices to reduce misdiagnosis at my organization. So we covered the topic and we asked you, and not as much as the root cause analysis, but 41% of you said yes, gave it a 10. For some reason, we got no 9s, 27% 8s. But this also indicated that you need this in 2016, so we'll deliver it. So we'll get the experts in misdiagnosis and what you could do practically at your inpatient or your outpatient organization as a safety or quality officer. What are the action steps to kind of get this in front of the right people, and where do we get started, and who's been successful, and what's the evidence that we can apply to really get the work done? We also asked, would you like a webinar dedicated to the reduction of misdiagnoses? And that is resoundingly positive, with 88% positive, but 54% of you gave it a 10. And so the 2% that said no, and the 7% neutral, and the 2% neutral, we'll cover this topic with another topic so that it may not be where your passion is, but we'll cover it in kind of a webinar where we'll cover two topics. So that said, we're now 18 minutes after the hour, and I want to invite Terry to be with me. Now as we go through, we're going to review the webinars that we've done this year just to remind you what's there, because there's some pretty hot topics that are good, that the payers are going to tie into that you really need to know about. We'll address the crosswalk between the E.H.R 10 hazards and the 10 technology hazards they identified for 2015, and we'll address the new 2016 hazards. And when I address the 2016 hazards, I'm going to ask Terry to respond to each one as a quality leader wearing that hat, or as a trustee, or with both hats. So Terry serves as the Director of Patient Care Services and is the Chief Nursing Officer at Shriners Hospital in Chicago. Under her leadership, they received the 2011 and 2013 Outstanding Nursing Quality Award for Pediatric Hospitals from the American Nursing Association. She also serves on the board of the Sinai Health Systems, and Sharon Rossmark introduced us, and we've had Terry multiple times on as a speaker and Reactor, and we consider it just a great privilege to have one of our chief nursing leaders who's also responsible for quality. And as she says, anybody that touches a patient, that's her leadership area where she is responsible. And she is one of those nurse trustees who is helping decode what's going on when a non-clinical board has to make decisions regarding resource allocation and understanding what's going on. So, Terry, it's such a great pleasure having you. with us, and I'll have you comment. I'll give you a cue when we want you to comment, and I'm just going to rapidly now go through a recap of the year. We've had a lot of great webinars, and a lot of folks have said, hey, you covered this. Where was it? Well, let me cover that for you quickly. Our January webinar, Nancy Conrad, longtime close friend, has been a tireless champion for patient safety, and one of our really great quiet servant leaders in the movement, Perry Bechtel, Dr. Perry Bechtel, who's a leader of neurosurgical anesthesia at the Mayo Clinic, but also was a Blue Angel flight surgeon. And when we produced our second film, Surfing the Healthcare Tsunami, it was through Perry that we arranged to fly with the Blue Angels and include them in the film. And they covered systems, safety systems failure, innovation, and high reliability. What Perry did also was took an accident, a skiing accident of his son, and illustrated how a small hospital did a great job with his son. And so I really highly recommend that you go, if you need some good examples of crossovers from aviation and high reliability, re-review it, and the link is on the website. Then what we did was the National Action Plan came out for adverse drug events. And we realized this is an enormous opportunity for us to do good, but an enormous opportunity for incentives. And now incentives are going to be tied to the three areas of adverse drug events that are medication errors. And it turns out that these cost an enormous amount of readmissions. They cost an enormous amount of money, and they are three areas we know a lot about. And yet we're still really struggling with them. So what we did was we focused on these three areas: anticoagulants, diabetic agents, and opioids. And we did one webinar each. And you gave us such a resounding positive response to the webinars that we added a fourth webinar, a review webinar of the three of the takeaways, had all the speakers come back. And we didn't think that we would get a high net promoter score, a high satisfaction from you, because a review webinar you generally wouldn't, because people say, well, you've already covered that. You gave us really great positive response of 10s because they're such hot and important areas. So the first one was anticoagulation, February 19th. Make sure to go back and listen to this. One of the top people in the world, Alan Jacobson, longtime colleague and collaborator with us, does a fabulous job walking through not only anticoagulation management and things like 50% of our patients just quit taking anticoagulants. We don't know why, within 2 years. And he addressed the novel anticoagulants, which was just critical. And there are a lot of new things that we don't know. You just can't put somebody on a novel agent and then not be testing them. And that was a big aha for us. And also, one of the leaders from the VA spoke with him as well, who was on the team for this national report. The second part of a three-part series was on opioids, 20,000 preventable deaths a year due to the opioids. One of the top pain management docs in the world, who's also board certified as a urologist. He's a urologic oncologist, an anesthesiologist, and pain management doctor. So he can really, and he's a certified patient safety officer, address the opioids. And we also had the Jody Tafton from the VA complement his input because she was actively involved with the CMS and the HHS study that we addressed in all all of the three parts. Then the third part was on diabetic agents, and we were honored to have one of the leaders of CMS at the Innovation Center, who's a PharmD, who's a real expert on inpatient anticoagulation agents, diabetic agents, Mary Andreas, Dr. Mary Andreas, as well as the outpatient lead on this project for the government as well. And he did a terrific job helping us understand the outpatient areas of interest as well. So these three were important. And then we ended up with all four of them speaking again on a fourth webinar. So if you wanted to get the takeaway and didn't have 3 hours to watch our webinars, you watch this webinar, it will give you the takeaway. So we just wanted you to see that. Now, we brought Perry Bechtel back with Dr. Greg Boats in June, and we started to address, and this is where we address these technology issues. So the 2010, and here's what's really important, the 2015 health technology hazards are a different set than the ECRI 2016, and both of them are still critical issues. So you really have ample material to kind of work with. And we looked at the crosswalk between the two, and Dr. Boats is one of the leaders here at MD Anderson, a great patient safety champion, and he also flies with Stanford on his time off to train nurses in accidents and critical care with the unit that flies out for Stanford Hospital in California. He's a Stanford alum. Then what we did was in July 16th, and this is another really important webinar, setting us up for January. So as you get ready, if you want, for our community of practice on electronic healthcare record errors and digital errors and harm, which will start in January with Dr. Toph Peabody, going back to listen to Ross Capel and really understanding what is going on with another one of our international experts that really addresses a lot of the gaps in this transition with health information technologies, not just the E.H.R., but the human interfaces with many of these programs. And then we had Fran Griffin with CMS and CDC. And the reason that I'm setting this up now, Terry, for what we'll talk about here with the cleaning and reprocessing of instruments and the CRE infections, the phantom menace, which is what the media calls it. We had the lead fellow at the CDC address that, along with Fran Griffin, who from CMS, the Innovation Center, addressed leadership. Again, this is great fundamental material to kind of build on. And now as I wrap up, in the fall here, we had Bill George, a longtime close friend, address leadership, the true north, the crucible, and how we really can learn from that. And then John Nance introduced us to patient safety cyber crimes in this electronic world and the E.H.R. world. And then we had John follow up with us with a deeper dive on healthcare accident investigations and the Red Cover report, and really set us up for January, when we will have a community of practice started. We're going to give you one webinar in January for everyone on electronic healthcare record errors and HIT, errors and harm, health information technologies that are beyond the E.H.R. In January. And then we're going to give 2 webinars a month from that point on to do a 3-webinar series, so that we'll stick to our core curriculum. But if you want to go part 2 and part 3 of the E.H.Rs, you can do so. And then we finished with Dan Ford and Clayton Christensen, which I already covered. So that brings us, and we're 28 minutes after the hour. That's the year in review, and we do this in order for you to go back, because a lot of the material that we covered this year is absolutely crisis-level patient safety material we will build on in 2016. But that brings us to the health safety concerns for 2015 and the top 10 technology hazards for 2015. Now, we've already covered them. We're not going to cover them again, but we want you to see that there were 4 that overlapped. Alarms, big issue. Data integrity and missing E.H.R. information in IT systems, 1 and 2. Mix up on IV lines ended up to be another overlap. And the 4th one was inadequate handoffs that actually was addressed with the reprocessing of endoscopes and that kind of thing. Now, when we look at what we're covering today, which is a new list, there's a little bit of a crosswalk or overlap with the 2016 top health technology hazards, patient safety hazards. So these 3 reports are absolutely critical, but we're covering these new ones that have just been released. They've just been released here a few weeks ago. And these are the top 10 hazards. And we're going to go through these top 10, and Terry will react to each one with me as we go through it. And we're going to poll you on how important you think they are. Please do the poll. And the reason is, you will tell us by how you rate them. It isn't ranking, so they could all be 10s if you want. But give us the highest level of intensity that you want us to focus on. If you think that the issue is a really important one to you, give it a 10. They could all be 10s. Whatever priority you would put on them, but you're not ranking them. You're rating them, and we'll go through each one, and I'll ask Terry to respond to them. This slide, slide number 50, addresses a crosswalk of all three. So basically, it takes the safety concerns that are the general concerns, the technology concerns are the middle for 2015, and you can see that there's a crosswalk for the 2016. By no means should you think that we think that the 2015 top 10, just because they didn't get repeated for 16, are any less important. They are. They're really, if you combine them, they're probably about 17 that are really super high, and 4 of those overlap with the general concerns. The first are inadequate cleaning of flexible endoscopes before disinfection. Now, we have someone very close to us who lost a parent due to CRE that was transmitted through scopes, entirely preventable, picked up by the CDC. I'm not going to read the slides. We've given you these slides so that you can see how this was covered in the press and the medical press. Here's an FDA. They pull the fire alarm. There's an immediate healthcare facilities review. We've got the references there for you. But this is a big issue. We've looked at the reference list and the full report. So my question is, if you read this question, the failure to adequately reprocess contaminated instruments, that is to clean, disinfect, or sterilize them before using them on subsequent patients, can lead to the spread of deadly pathogens. If you think that's a very important issue to you, give it a 10 or give it a high number. If not, give it a lower number. And I'm going to ask Terry to respond to this issue, and we're going to go through each one by one to give you a chance to respond to the survey. Please respond. It will drive our agenda in 2016. Terry.
Thank you, Chuck, for allowing me to share my insight on these things. You know, if you were to ask me, was this an important topic, I would say, you know what, that doesn't happen at my hospital. And I think as a nurse leader, we need to understand that things can happen. And we have such a high level of oversight that sometimes we don't see or get the reports that we need to get to make sure that staff understand the importance of following the manufacturer's process for cleaning equipment. And so that's number one. And then number two, once we understand that staff have to follow these processes, we also have to make sure that there's a monitor in place to make sure that nothing slips through the cracks. As a trustee, if something is new and we see something that hits like a sentinel event or what have you, it is the responsibility of the quality committee to know about these things. And the trustee, as a trustee, I would ask that question: what are we doing? Our staff trained? How many of these incidents did we see? Did we have any near misses? And then to let the staff know, we will be looking at this on a monthly basis. So for me, this is training and making sure that no one's taking shortcuts.
Fantastic. Thank you, Terry. You've given us both dimensions, which is terrific. The second one, and this popped up on multiple lists and continues to be a big issue, and we're going to play a 5-minute audio tape from TOF regarding addressing this. Missed alarms. Joint Commission announced the 2014 National Patient Safety Goal addressing this area. AAMI, Clinical Alarm Summit. It's popping up on every one of the lists that we see. You always are seeing this, and so we haven't solved it. And if in the free text entry content later, please let us know if you've cracked the code on and have some success stories. We would love to hear about them. So on missed alarms, the question is, failure to recognize and respond to actionable clinical alarm conditions in a timely manner can result into serious patient injury and death. Are the alarms a big issue, and do you want more on it? And that we're asking kind of that you're giving us, if you believe so and you want us to cover it and you want some experts to brief us on this next year, give it a 10. And so this is a critical issue. Terry, do you want to address this, and then we'll move to the next?
Yes. So far as when we look at alarms, just think about you've had someone in the hospital and they had an O2 stat alarm or monitor on their finger. They take it off and the alarm goes off, or the leads are not attached to the patient the way they should be, and so the alarm is going off. Well, oh, that's Mrs. Jones. Her alarm, her leads keep coming off and off. We have to make sure that, Mrs. Jones is on a monitor for a reason. And so it's very difficult if you do have a mishap or fatal consequence to explain this to the board that, well, it was alarm fatigue. We heard it, but we just thought it was something else. So it's important as nurse leaders that we make this information, that we put monitors in our performance improvement to make sure that we are definitely double checking that our alarms are right, that we know what alarms are there, that they don't all have the same pitch. You know, when our general alarm goes off here, everyone knows what that is, and we don't hesitate, we evacuate. So I think this one is an important one for not only the trustees, but also for nurse leaders.
Thank you, Terry. Absolutely. Perfect. Next one is failure to effectively monitor postoperative patients for opioid-induced respiratory depression that can lead to brain injury or death. You know, Dan brought up the issue of what happened to his wife. One of the deans of one of the most noted and excellent medical schools in the country in the last 2 years had this happen to him and had to be readmitted after an elective procedure. This isn't just happening to the occasional patient. This is happening much more frequently, especially as we accelerate people out to SNFs and to other sites. So we pulled the data on this. Sentinel event, you all are probably all familiar with. And as well, adverse drug reactions in patients, and an analysis of episodes reveals that opioids are a big deal. And you know, if we sit down and say, Terry, what should a trustee know, and what should we focus on? If CMS has identified opioids as a major target and one of the three classes of drugs that is causing preventable adverse events, cost, and harm, and you have this popping up on ECRI and with Joint Commission, it doesn't take a rocket surgeon to figure out that we better keep focused on this with the opioid issue. So the question is, hospitalized patients receiving post-operative opioids are at risk for drug-induced respiratory depression, which can lead to anoxic brain injury or death. Is it important? Do you want us to address it this next year? Give it a high mark. If not, a lower mark. But love to hear from you. Please give us the feedback on this one. Terry?
You know, for me, when I look at and think about failure to effectively monitor postoperative patients, the one thing as a nurse leader, I want to make sure my staffing is correct. Do I have enough staff? You know, sometimes we get fooled and we think that, okay, we're on a telemetry, so, you know, you can sit there and you can monitor several patients. A lot of times you have to go and you have to make those rounds. So for this one, my concern here as a nurse leader is to make sure those our units are staffed correctly, that our staff are trained and understand the importance of identifying what's on that monitor so that we don't have patients being rushed back to the ICU.
Fantastic. So the fourth one is inadequate surveillance of monitored patients in a telemetry setting may put them at risk. Hey, a no-brainer. We expanded this a little bit because of the paucity of what was in the research, and we know that monitoring and continuous monitoring, even before, during, and after surgery, has had enormous impact in organizations such as Dartmouth and others. And so keep an eye on this. We think that this is going to be a very important issue, but it'll be beyond just those in a current telemetry setting. And as we start to do telemetry and have the technology available to have it up on the floor and early sensors and these different technologies that are available to let us know what's going on the floor, it's going to be important to be able to watch those and monitor those. And so the question here is, or the statement that you would then react to is, inadequate surveillance of monitored patients in telemetry settings can lead to unrecognized critical events and subsequent patient harm. Terry, your thoughts?
My thoughts go back again to training. Most hospitals nowadays either have older staff or very young staff right out of school. And so we have to make sure that our staff their preceptors are adequately trained, and so that they can recognize when patients are deteriorating and that they know how to use the chain of command. And so for this one, it's very important. This is a people thing. Your computers and your monitors can tell you a lot, but look at the patient. And so for this one, I would say training and competency of the staff is the most important thing for me on this particular topic.
Boy, what a great comment. And, just to affirm what Terry's saying, we're getting an enormous feedback from out in the front line that this is a critical issue. We hear people going into the patient room and not looking at the patient and copy and pasting the historical data and then having enormous errors. But people are getting so into the magical thinking that the telemetry will substitute for watching the patient. And I think thank you for sharing that. Number 5, insufficient training of clinicians on operating room technologies, which puts patients at risk. So these are some of the references from the full report from E.H.R addressing this. It's been covered in substantive journals, and this really is something that is popping up. I'm at one of our major medical centers in the world today, had a meeting this morning with the head of R&D who said that many of the companies are insisting on their people coming in to help run the equipment, and they don't know who these strangers are. And talk about the concept of stranger danger, in that if your staff don't know how to run the equipment and somebody comes in from the outside and no one really knows and has been checked out on the equipment, it takes us back just to what you said, Terry, about training. So the question is, or the statement is, insufficient training of clinicians on operating room technologies can result in use errors that puts patients at risk of harm. Please give that your rating, and Terry, your thoughts.
Every hospital wants the latest and greatest, because that's going to push volume and it's going to bring patients in. And, surgeons go to conferences all the time and they come back and they want that new thing. And so I would suggest, as a trustee, I look at this and say, well, how do we know you're trained to do this? Are we utilizing the simulation labs for training? And then how many do you do? Is it you see one, you do one, and you teach one? And then once the physician is trained, what about the staff? Who's going to come in? And so sometimes we have to back off and slow down a bit until we know that what we've done in the training, so that we don't harm our patients. We know patient safety is number one, and so we need to make sure that that's in the forefront.
Absolutely, and again, I mentioned that I'm in Houston here, where I trained many years ago, and my first area of research as a PI was photodynamic therapy using lasers to activate an inert substance that then killed cancer, and ultimately became a laser safety officer. And the number of accidents with lasers, because people hadn't read the manual and didn't have the competencies, was off the charts. And there was no way to really even keep track of them. There were thousands, even in the state of Texas. So very good point on the training, Terry. On number 6, errors arise when HIT configurations and facility workflow do not support each other. No-brainer to any other industry, but since we're so busy taking care of patients, it's oftentimes hard to know just how to adopt them. In fact, when we wrote, and Arlene, you will remember this, when we wrote the National Quality Form Safe Practice for CPOE, Computerized Prescriber Order Entry, with excellent co-authors that worked on it, David Klassen and others, we took an enormous amount of time focusing on the care process flow, and that CPOE was the capstone to really well-engineered processes. And you can see from the articles, which I won't address, there have been so many articles this year on E.H.R. adoption and configurations and challenges, and Top will address this as well, so I won't belabor it. But I'll just read the statement. Poor alignment between the configuration of health IT systems and the facility's workflow, and that's the workflow both of the caregivers and the flow of patients, increases the opportunity for medical errors, putting patients at risk. Clearly, if we address our care reengineering and use the technology to help us, fine, but my question is, rate this, if you would please, if you'd like help on safely adopting these. I think that there have been some great webinars this year by others addressing getting a safe E.H.R, then using a safe E.H.R safely, and then using the E.H.R for patient safety. And you've got to get the first two, and the number two, using it safely is critical. So this one, I personally rate this as a 10. We'll see what you all think. Terry?
You know, I agree with you. Technology is a tool. It cannot see the patient. We see the patient. And so when you have pre-populated fields, when you're on your electronic medical record, you still have to read them and verify that these things are still okay. And the one thing that pops out in my mind is the MAR. You know, are you on these same medications? Did it change? Are you taking a half a pill or are you taking a whole pill? And we have to take the time and talk to our patient and use the device as a tool, not the end-all and be-all.
Fantastic. And so important for trustees who are writing these enormous checks to understand that just the check written to the vendor is only part of the allocation of resources, and a big chunk has to be dedicated to the care process reengineering. And we'll have Frank Guilleteau, who will react at the end of this review of these as a biomedical engineer to that. 7, unsafe injection practices expose patients to infectious agents. Frank and I actually worked on this years ago with Premier in terms of the syringes and, the AIDS epidemic and a lot of the challenges we had there. And there are numerous references that you can see that we pulled for you. There are many more than we pulled for you, but we think if you're going to be briefing your staff, these are some WHO, Joint Commission. It doesn't get better than that in terms of the references of what's really critical. So the question here is, and I know you'll have some great comments to this, Terry, as a nurse, having been a frontline nurse and responsible for everybody in your organization who touches a patient. Unsafe injection practices are an ongoing patient safety concern, both in hospitals and in outpatient settings. We know from some of these mass infections that occurred on the outpatient basis, we still haven't cracked the code on this one. So we'd like to have you give us a rating of this one and whether you want us to address it next year through that rating. And Terry, your comments.
Excuse me, Chuck, to me, this one again, as a nurse, I'm just in awe. If your vial says single use, then that's what it means. And so as a nurse leader, this message has to get across. And perhaps, and this isn't the first time that we've seen it, perhaps we're not delivering the message and letting our staff understand just how important this is. It's a single-use vial. That means that you only use it once because the consequences are so high if something goes wrong with our patient. So this one troubles me. This would be a 10 for me, absolutely.
Great. Number 8, gamma camera mechanical failures that could lead to serious injury or death. This was hard to find data on, and we're going to be doing more work on this. As a former radiation oncologist and having taught biomedical engineering and worked with technologies, this one is one where we just don't have a feel for how big an issue it is, but it's popped up on the grid. We think if ECRI says it's important, it's got to be important. This may be a low frequency but a high impact event. We're going to do more research on it, but you may know more than we do and likely do. So please tell us if you think this is a key issue, you need more on it. Give us a ranking here. And Terry, this is back to the trustee. You know, when we see these issues pop up on the grid, how do we address the low frequency, probably not going to happen in our place, but high impact event when we talk to boards?
I think what's important is to make sure that, first of all, that we do bring it to the attention of the board. And then secondly, we have to assure the board that here are the steps that we have in place. We do our PMs. We do our preventative maintenance on all of our equipment. If you want to drill down and see it, we'll be happy to let you to know about it. And then say, if this is a new piece of equipment, it's under warranty. And for me, this is a people thing. This is more of a preventative maintenance, and we do bring it to the board. But the board can't get down in the weeds. It's a really high level. And so when you see something like this, I mean, I was surprised. I was shocked. The board definitely needs to know. And if we don't bring it to the board, they're going to bring it to the nurse leaders and your CEO.
And that's a no-no. You don't want that.
No, we don't want that. So it's better to bring it forward and say, this is how we're preventing this and how we're checking this.
So my recommendation, if you're a safety or quality officer, is just grab this slide or grab this topic or the reference and just ask your radiology manager, just checking in with you, is this an issue for us? And just let me know so I've got that in my quiver if I need it. Number 9. Failure to appropriately operate intensive care ventilators can result in preventable ventilator-induced lung injuries. So these are ventilator-induced injuries. And we pulled the references on this, not an area of depth for me personally as a clinician. I'm going to call on Dr. Greg Boats and others who are ICU doctors at top organizations to help us understand this. And if you give this a high rating, and you want more on it, we will definitely have 2 or 3 really good leaders help us understand not only what happens, but how you prevent it and what you need to do to prevent it, such as training and awareness. But please bring this one. You may know more than we do. Please let us know if you want us to address this inappropriate patient ventilation issue, how it can cause the ventilator-induced lung injury, particularly in the ICU, that may lead to patient death. Again, we trust ECRI. We think they're a great resource. If they made it a top 10, this is something that we're going to dig into to find out. But give us how you think it's important. And Terry, thoughts here?
Technology again is a wonderful thing, but clinical data should be what drives and leads us in caring for our patients. And so evidence-based practice is, I think, the key here. And we need to discover ways to incorporate that into our technology so that we're not making mistakes.
Great. So thank you, Terry. So now as we go to number 10, misuse of USB ports. Now, this really surprised me, and I know, Frank, you may have some comments here. The misuse of USB ports can cause medical devices to malfunction. I have not, I've seen that happen with my own computers, and I have a number of them, and I have big files, and I've been able to have things go down when I've had multiple peripherals tied to a PC. But when we pulled the data on this, it's cybersecurity risks are key issues, but also causing a malfunction of the equipment is an issue. News to us. This was new. We hadn't seen this pop up, but with ECRI, we're digging into it, and we'd like to know what you think of it. This was new to us. When the report came out, we were surprised, and we're not experts in this, but we're going to dig into it on your behalf. And go ahead and give us a ranking here. Terry?
For me, this is more of a trustee issue because this could be devastating to the entire organization. And so we have to make sure that there are key things that are in place. And as we learn more about this, the board needs to be educated on it.
Mm-hmm. Fantastic. And when we get to more of our dialogue a little bit later, I'd love to hear what how a quality committee, you're a chair of a quality committee, can do that. So to set up our next section, we just wanted to remind you the number of articles that have been hitting the press. If you don't have E.H.R. related safety and quality issues that are popping up in discussions, then you're one of the few, because we're seeing this all across the country, article after article after article. These are just some of them, and that's why when we polled you regarding a community of practice, and then shared some of the work that is really valuable in this space, you said, yes, we want a community of practice. We asked how many sessions would 3 will work. We're going to start the first one in January. Toff Peabody will co-lead it. We may have John Nance as well in January. He will be part of it because he helped us really addresses cybersecurity. Frank Guilleteau, that is a Reactor today, contributed. We'll have him be an invited Reactor. But to just take you back, for those of you that haven't seen our webinars, this is a very valuable report, IOM report 2011. Very timely. It addresses these issues. And also, we want to remind you that the Office of the National Coordinator of HIT is asking us to be able to submit to them issues that we believe are really critical in HIT, and there are many of them, and we want to remind you of that and suggest that you submit those. So as a setup to the community of practice, and also to get Toff's reaction to these, since he was covering an emergency medicine shift at UCSF, we have a recorded statement of Toff, and then we'll come immediately after that back to our Reactor panel. So, Kyle, would you please play the 5 minutes of Christopher Peabody, Toff Peabody from UCSF. He's Assistant Clinical Professor, Department of Emergency Medicine. We met him 7-8 years ago at Harvard. He's been a wonderful contributor to educational programs we've done for medical students and then during his residency. And he's also one of the originators of Dream Teams to help folks maintain their focus on core values as they go through training. So, and he's one of the top people in health information technology related to acute care. So, Kyle, would you please play Toff's reaction and the introduction to the community of practice?
Chuck, thanks so much for having me back. I love being on your webinars, and I think today's webinar was especially informative. I'd love to react to a couple of things that were discussed on the webinar today, especially related to those 2016 top technology hazards that were just released, to discuss some of the upcoming items that we may be talking about in the future for next year. And then invite the audience to come and join our community of practice that we're going to be starting next month in January, the Health IT Community of Practice that we've been working so hard on, and I think is going to provide a lot of great impact and some very simple solutions to what look like complex, intractable problems related to patient safety and health information technology. So I think there's some simple things that we're going to be able to do with our community of practice that you're going to be able to roll out right away, just immediately after this community of practice meets. So I'm really excited about that prospect. But let's first turn to these 2016 top technology hazards. I think my first overall reaction, Chuck, is that I really see technology's role as being able to help the patient, help the provider to keep their patient safer. And it's just amazing to me that some of these systems that we rely on every single day in the hospital, in the clinic, actually may cause patient harm. And the way we use and interface with some of this technology is the cause of that harm itself. So it may not actually be the device or even the electronic health record or the health information technology system itself that causes patient harm, but the way that the physicians, caregivers, and even patients sometimes interact with those devices is the reason for that harm itself. And so that's my overall kind of take on the new top 10 list of technology hazards in 2016. More specifically, when I look at some of the top 10 lists, a couple of them that come out to me, that jump out to me right away, is looking at number 2, missed alarms can have fatal consequences. Now, we all know about the phenomenon of alarm fatigue. I really think that we need to be able to interact with our alarms in different ways, and that means that we need to have smarter alarms. And so we're going to be talking about this a little bit in our health information community of practice, but we need to have a solution for this phenomenon of alarm fatigue, and we need to be able to distinguish when our alarms are signifying something that could be life-threatening. Turning to the top technology hazard number 3, failure to effectively monitor post-op opioids. This really, Chuck, reminded me of the conversation that we had with Dan Ford last month, who was on the webinar. And this really jumped out of the page to me because I know through Dan's efforts, wanting to have rescue devices and better monitoring for post-op opioid monitoring was really one of the reasons for the extremely unfortunate case of Dan's wife's opioid-induced hypoxic brain injury. So in the spirit of Dan Ford and all the work that he is doing to actually get patients involved, not only in monitoring patients' care as it's going on, but also in the post-hoc analysis and trying to get patients on the teams that are in hospitals doing root causes analysis. So getting patients on those boards where root cause is actually happening, getting the loved ones that were actually there during the experience to get the patient perspective. I think this type of idea can translate not only to the practice number 3, which is where Dan was so effective in advocating for actually having reversal agents for opiates on the floors and better monitoring devices, but can also be applied to pretty much every one of these top technology hazards of 2016. And so how can we involve the patient or the patient advocates in discussing how we're going to approach and come up with the solutions for these 2016 top technology hazards? Now, technology hazard number 5 was really an eye-opener to me and really was kind of a bright red alarm light for those of us that are involved in any decisions related to E.H.R, onboarding, patient safety officers, in that insufficient training of clinicians on technologies actually puts patients at risk, especially in the operating rooms. This was kind of an eye-opening one for me, Chuck, in that I really think that we need to focus on our processes on when we get onboarded to new technologies. When new technologies are introduced into our clinical practice, how do we actually get signed off on being able to use this new technology, and how can we do that safely? So I think really focusing in on processes is going to help us with tackling number 5. Turning to, again, the top technology hazard 2016, number 6, errors arise when HIT configurations and facility workflow do not support each other. Now, this is something that I'm very, very interested in, and something that we are going to be focused on with a laser-like focus in our health IT community of practice that's going to be starting next month. It goes back to the concepts that we've been kind of discussing throughout this webinar series in the last few months. Health information technology is not a panacea. You can't just roll in a new electronic health record and then expect everything, all of our systems and workflows to be miraculously safe and highly reliable. So a lot of the errors that we see in using health information technology has to do with how that health information technology is incorporated into our existing workflow structure. Now, as an example, in the emergency department, how I've seen health information technology systems, especially electronic medical record systems being rolled out in emergency departments, is actually quite disturbing, in that it has actually decreased the amount of communication, face-to-face communications, that the healthcare team has with each other. So I can tell you, Chuck, right now, around the country, there's a nurse going in to see their patient. They're going to do an extensive assessment on the patient, and they're going to go back into their area to chart. And they're going to chart into the health record and hope that is now, that information that they've spent so much time gathering is then communicated to the physician and other members of the healthcare team. Now, the physician may leave their area where they do their charting on the electronic health record in the computer, go see the patient separately, come out, write orders, and communicate again through this electronic health record. The workflow in high-risk situations really needs to focus on getting the right information at the right time to make the right decisions for our patients. And somehow this siloed workflow does not provide that communication that is necessary, that face-to-face communication as an entire team. So how can we use health information technology to improve our communication and workflow? This is something that I think is highlighted in this top technology hazard, number 6, that we've just been discussing. and it's also something that we're going to be discussing further in our community of practice for health information technology. So Chuck, I'd like to invite everyone that's listening today to join our community of practice in health information technology. We're going to be focusing on simple solutions that you will be able to implement in your institution directly after the webinar. We will be presenting the 8-dimensional socio-technical framework to get a better understanding of how health information technology relates to patient safety and how many different aspects of using technology can actually cause patient harm. So we're going to first understand the problem and then really jump in and dive into these simple solutions. And we'll be doing so by using some of the self-assessments that are endorsed by the Office of the National Coordinator and really reviewing a lot of the safe practices that is related to health information technology. I look forward to seeing everyone there and look forward to participating in more webinars to come. Thanks again, Chuck, and have a great holiday season.
Great. So that was a great summary. And just so everybody knows, the webinar for January will be on health information technology, patient safety, same format we usually do, and it'll be the launch of the community. And then if you want to watch the second and third webinars, they'll be posted at another time so we can cover the other topics. I'm going to open things up just in a second to go to Frank Giotto and have our reactor and give Terry a chance to react and Arlene as well. But what I wanted to do, because I'm watching the time, so that we can include in our discussion with reactors a new program that Terry and Sharon Rossmark really envisioned that I think is fantastic. And we've agreed to fund doing this and for a 3-webinar series on preparing and helping nurses who would like to understand how they, what the need is and how they could become a trustee, because there's a critical need for nurse trustees. So basically, and Terry came up with the name I love, Ready, Set, Go. Ready is the first webinar will be what nurses need to learn to be trustees. Maybe they don't want to be once they find out what they have to do. Why they are so critically needed, why it is so enormously valuable to have a frontline nurse with her or his experience be brought into the boardroom, and what they need to do to be ready for the call. All you have to do is just start to pray for something and things happen, and or to pursue that calling. Either way, set means the preparation to serve as a nurse trustee. You may like the idea, you may know there's a need, you may think you're valuable, but what do we really need to equip ourselves to have the competencies in for the right organization at the right time for the right purpose? So that would be the second webinar of the 3-part series. And then the third is Go. Once you know what it's about as a nurse, or a nurse colleague of yours knows that, if you want to share this with them, and you've prepared, how do you pursue becoming a trustee, pursue a position? What's the proper protocol? How can you explore the opportunity? Who needs such folks on their boards? And how long does the process take? And how do you organize yourself to be able to pursue it? Because it's not just going to happen. This is something that one needs to understand, get prepared to do, and then how would you go about following a checklist to pursue an opportunity to be a trustee? So it's a webinar series of 3 90-minute programs with checklists and tests, a certification and a certificate of completion in CEUs has graciously been offered by the University of North Texas Health Science Center to do that, and the program will be entirely free. We think it'll be a pilot program, and then later, if there's a way we can cover the costs, if we have an ongoing program, great, but this is an experiment, and we think we'll have absolutely terrific people leading it. And just to give you an idea of who would be involved, Terry, who's on this call and who I'll have react to and maybe frame the idea even better than I did, Sharon Rossmark, who couldn't be on the call today, who also has suggested and committed now to provide a board brief for every one of our webinars in 2016. We're going to have a 3 to 5 minute recorded, if aren't available, or live board-focused message that we can have at each one of our webinars. And then Mary Foley, our longtime friend and colleague and part of our Saturday morning team that pushed the hacks through, who's the former American Nursing Association president, drawn to patient safety through an accident in her own family, and a full professor at the University of California, San Francisco, who has also agreed to be faculty. And there are many others who are nurses who are on boards who I'm certain will want to participate. So I'm going to turn it back over to Terry to have you frame the need a little bit for us, and then we'll go to Frank Guilleteau after that to react to everything we've heard, and then Arlene. Terry?
Nurses need to be on boards. And when I look at myself, one of the things to get ready is to decide, why me? Am I capable? Do I have the confidence? And it took a lot for me to say to myself, I can do this. And so that's why I think this is important. When we looked at the data, in 2013, I believe there were only 6% of hospitals in the United States had nurses on their boards. Nurses are the front line to the patient. However, they had 20% of physicians. On the board that I sit on right now, I have to definitely decode what's going on and ask the appropriate and critical questions so that we get a better idea of what really is going on. So it goes down to patient safety and making sure things are on track. I'm really excited about the three webinars. I'm hoping that people get as excited as I am, and that they can realize that they too should be and can be on boards, and that they are a valuable, valuable asset to any hospital that would have them.
Fantastic. So Frank, do you want to maybe react to this board issue, since it's the last issue that we've covered, and then we'll go back to technology? Maybe have you react to the nurses on boards issue. You and I have worked together for more than 20 years. We've seen the great value nurses can bring that has a different lens and perspective than doctors. And then we'll ask Arlene for her comments, and then we'll come back to the technologies.
Yeah, certainly. I think Terry, we were talking before it started, highlighted the importance of bringing that unique lens as a nurse. I mean, if we are looking to have governance board that balance the financial and fiduciary aspect as well as the quality, and we're looking at 50% of the time being focused on quality and 50% of the time being focused on finance. It's critical to have the equal representation, or at least, as Terry highlights, an interpreter as to what's going on at the front line. And if we were to go through these technology hazards, who is, within the context of the board, capable to interpret and prioritize and really articulate what the strategy should be at a high level in order for us to tackle them. And I think the individuals that are on the front line, whether they be clinicians or the nursing staff, can provide that unique perspective. So having that initial spark of raising the awareness that as a nurse, you have the opportunity not only to impact the care at the point of care, but also taking the step to be part of the board and really drive some of the key elements that you see as a frontline engaged worker can have, I think, a dramatic impact on the overall quality of the organization, and obviously and a dramatic impact to the patients.
Well, fantastic, Frank. And I'll go to Arlene, and I want to kind of address the issue of why we pick nurses, because I'm certain so many of you are respiratory therapists or have climbed the ranks in pharmacy. And why did we narrow it just to nurses? And the answer is that this is going to be an experiment to take that narrowed bandwidth of the nurse we think that there's an enormous opportunity for pharmacists, for caregivers like you were, Arlene, and respiratory therapists and PTs and PAs and allied care personnel. But we thought we're going to tackle, we debated this and really thought this through, and we think we've landed on the right thing for this particular pilot to see if a nurse-specific approach addressing nursing issues right down that narrow bandwidth will be valuable, and then expand it from there. Because I firmly believe that as equally important having a nurse on the board, it is to have a pharmacist on the board or other caregivers. And so, Arlene, please react to this program, knowing that if it's successful, we're going to do it more broadly for caregivers in long-term care facilities and in the environments where you practiced, as well as been a patient champion. Arlene.
I think it's a great idea. I think we need different perspectives. And I was a frontline worker, but I was non-clinical. And I saw the nurses every day. I saw the patients every day. You get a different perspective when you're actually in the trenches, working the floor. And I think that information that they bring back to the board is so valuable because, like Terry said, they do have a different perspective. They're working the job, and the board needs to see that perspective. It's important to get all the data from all different viewpoints in order to make improvements. So I think it's just a plus to have nursing on boards. I think it's great idea.
Great. Now, Terry, we're going to loop back to Frank now and go back to the technologies so that we can cover that properly. I thought it was just that for time, it was best to kind of shift to the nurses on boards. Let's go back to some of these issues. Frank, as a biomedical engineer who's worked with us for many years, have really a great appreciation for the human-machine interface and how how we dealt with over many years trying to figure out how to tackle these. Are there any of these specific technologies of the top 10 you've seen for 2016 you want to address, or do you want to address them parenthetically and broadly?
Actually, I think maybe a little bit of both. I think overall impression, much like Todd indicated, a number of these are clearly linked. And when we talk about technology, obviously we're talking in a pretty broad term, but I think it's been touched on by both he and Terry that many a times we take the technology threading there and think it's going to be the solution, while in fact at the end of the day we're just talking primarily just an enabling a process. So first you need to step back and understand the system, and I think if you look at some of the issues around the alarm fatigues and or the opioids, even telemetry and configuration of the HIT systems, all these are in some respect interrelated in the sense that if you don't have the right workflow and if you don't have a clear understanding of how the technology is going to facilitate delivering care, you may just be adding another process step that's going to have a negative downstream effect or add complication to the system. So I think it's very important as we look at all these, we take a kind of a broad picture. And Terry, I think, provided a great context in keeping it at a high level, because ultimately, if we're going to address these, we can't just look at them individually, but also we need to translate them as to what does it mean to the leaders and the leadership, be it the board or the C-suite, how we're going to start making some changes. And I think it's important to look at them and say, okay, if we are looking at doing training, or if we're doing a process redesign to put in place a new HIT system, what are going to be some of the risks associated with the deployment, and what are going to be the broad benefits that we're going to get, so that we can articulate that as part of that process, we will be addressing multiple aspects of these issues, as well as making sure that we understand that we're having those issues. So from a technology standpoint, again, it all goes back to an understanding of how the system operates and how we can optimize it. I was kind of surprised to see a couple of other issues that popped up. I think we've touched on the reprocessing of of these endoscopes. And I think it's a topic that was well covered by one of our prior webinar, and Dave Pertz, I believe, was saying. But one of the areas that also kind of popped up, not only to the patients, we also saw some potential impacts to the people that were doing the reprocessing from chemical exposure. So this is one area I think that deserves a lot of interest and focus, not only in the inpatient environment, where usually there's a little bit more of a robust framework and quality in place, but I think very importantly in the outpatient setting, where there may not be the same level of scrutiny or the same ability to have a quality system that is, enforced and maintained. And that's one area, I think, because of the nature of where these devices are used, it's very important to go very much outside of the hospital and looking at the outpatient environment. Maybe I'll touch on the USB connector one, which kind of raised my eyebrow in terms of a technology. I think everyone's always looking to bring their own devices in any environment, whether you're traveling, also at work. So I think the risk there sparks from the BYOD, bring your own device, and the risk of plugging devices that are going to be looking at potentially updating or connecting with whatever technology that's in the inpatient setting. And there's always a risk of that communication bringing in a potential virus or Trojan that could be deployed and ultimately damage or affect the technology. So I think that's probably why there are some concerns. I think certainly bring your own device is a risk to any HIT environment, and I think we need to be well aware of that and put in place some of the guidelines for letting employees bring devices into their environment. So, Chuck, overall, I think this is a really very interesting list, and I think a lot of those elements have an overlapping issue that go back to, whenever we've been looking at technology, we need to understand how it's going to affect the overall system and what are the socio-technical issues that we need to bring into play so that when we're deploying an environment, we're doing it safely and have the impact that we're seeking.
Great, Frank. Now, Kyle, please put up the second, there we go, the second poll. I shifted around a little bit back and forth between our nurse trustee course just to give all of you a chance to finish the polling if you were delayed that we had covered. So now as we're close out this webinar, I'd like to draw you back to the nurse trustee training course. Give us a rating of how important you think that is. And it may not be for your organization, but your opinion as to how important you believe it is that we undertake this pilot for training the Ready, Set, Go program, a 3-webinar series for nurses specifically, to be able to earn CEU credits, get a certificate of competency of the content, because we'll have a test after each one so that we actually have, we know that people have learned at least what we've presented, and help them prepare to understand, to get ready, and to know how to pursue the right organization to be a nurse trustee. Please give us that. And then also the topics. Many of you may not be nurses, but you really believe that there are certain topics that nurses should learn through a trustee training program. What should we share with them that is valuable? And I'm going to go back to you, Terry, now that we have this free text entry question. It's the last question. I promise no more polls today, but we would love to have input from you on what you believe that nurses should learn regarding pursuing a trustee position, a governance board position, and really anything you believe would be important. Please put in the free text entry. Terry, can you give us kind of a bit of a rundown of what you felt, what you feel should be in the program, and what topics you feel that are critically important for nurses to learn to bring to boards?
I think more than ever, nurses need to know, or trustees need to know, how to network, how to communicate effectively, And also, as a nurse, being a trustee, you have to make sure that you set boundaries. And so when you are at the board meeting, you're not the chief nurse. You're the trustee. And so you have to allow for the chief nurse to be the chief nurse and understand her boundaries and your boundaries. So I think that's one. I think also you have to be able to have a very high-level view of what's going on, not just the clinical, but also the IT, also the finance, and how that affects all the little dominoes that make up the organization. I think also for me, and this would be the last one, would be strategic planning. It's not just a document that you write and you put on the shelf. You have to know all the elements of it to make it work. And if it's a good strategic plan, it really helps the organization. And as a trustee, that's what you use to push it forward, to push the organization forward.
Fantastic. What great comments. Terry, we are so grateful that you have come to our organization and are contributing to help us with this topic. Thank you for your passion for nurses to be on the boards and for the great insights that you've provided to us. Frank, thank you for your contribution over the many years and specifically on both the technologies but also on this board perspective. We'll get to finish a couple minutes early because we've covered the waterfront. What I'm going to do is I'm going to turn things over to Arlene to close us. But what I wanted to do was just remind you that we were very pleased to see a leading innovation in patient safety summit that was undertaken by the University of North Texas Health Science Center. We want to thank them for volunteering to do the certification for the nurses on this course that we are going to undertake and offer for free as just a goodwill effort to see if it works and see if it's of value. Innovators have to do that. We have to fail forward or fail fast to succeed faster, and they're in it with us to make sure that nurses get some real value in their credits and their certification. And we wanted to remind you that the courses that they offered at this meeting are available now at the University of North Texas Health Science Center, and a number of our great leaders over the years have been speakers. So John Nance, Clay Christensen, Sharon Rossmark, our Saturday morning team, Steve Swenson from Mayo Clinic, Mike Henderson from the Cleveland Clinic, Toff Peabody, who you've heard today, all speakers at this wonderful meeting. And so we'd like to draw your attention to go to be able to watch their content that they delivered there, including the CDC. We had Arjun Srinivasan, Dr. Srinivasan from CDC address the Ebola issue. We had the physician who was the chief quality officer at Texas Health Resources when the Ebola ground zero issue hit. Dr. Varga, who was just a terrific physician and a terrific leader, addressed the issues that he felt important. So now as we close, 27 minutes after the hour, Arlene, you are just one of my heroes. You take on this controversial issue of bullying with such grace and just with such a wonderful faith-filled approach, and you've been such a contributor to getting the hacks through and the NQFSA practices. We can't say enough about you and the Saturday morning team, along with Mary Foley and Jenny Dingman and Becky Martins and Dan Ford and Mary Foley. So thank you for being part of that team, and thank you for closing. And we hope everyone is just has a wonderful, blessed Christmas and holiday season, and we wish you all the best and look forward to January when we kick off our Health Information Technology program in January, the third Thursday of the month. So, Arlene, please go ahead. Thank you, Terry. Thank you, Frank. And thank you, Toff. Although you're not here, we know you're taking great care of patients.
Okay, thank you, Chuck, for all those kind words. I'm really looking forward for next year and everything that we'll be doing and covering. And thank you, everyone, for the informative presentation today. As Terry mentioned, proper staff training seems to be an issue that comes up more and more, and reinforcing training is so important. And I think just as important is teamwork, and teamwork on your front line. So setting up an environment that invites frontline workers to be proactive and they feel comfortable to bring potential harmful situations to their supervisor without criticism or without retaliation is key. So I would like to ask everybody out there to see the value of your frontline worker and get them more involved in your patient safety efforts. They have a wealth of information to improve your healthcare facility. And also, I would like to ask everyone to include patients and their families in every aspect of their care. And that is especially when things go wrong. Don't abandon them. Have patient-centered care all the way through. So thank you very much for having me on and representing the patients. And everybody have a good holiday season. Thank you.
Thanks, Arlene. Speakers, stay on. We'll do a quick process improvement loop.